Hello guys, welcome to AI Medical School. In today's video we are going to study a very important topic of ENT, which is otitis. But before starting the lecture, if you are still have not subscribed to the channel, hurry up, subscribe to it and hit the like button. These are the different otitis. Otitis externa is inflammation of the external auditory canal or auricle. Otitis media is middle ear inflammation. Suppurative otitis media is fluid in the middle ear, presence of signs or symptoms of infection. And otitis media with effusion is fluid in the middle ear, absence of signs or symptoms of infection. Otitis media is stratified into two distinct categories: acute otitis media and otitis media with effusion. The most common bacterial pathogens that cause acute otitis media are Streptococcus pneumonia, Haemophilus influenzae, and Branchiomyceteralis. And otitis media with effusion is defined as the presence of a middle ear effusion for 3 months or more. Otitis externa is an inflammatory and infectious process of the external auditory canal. Pseudomonas aeruginosa and Staphylococcus aureus are the most commonly isolated organisms. Less commonly isolated organisms include Proteus species, Staphylococcus epidermidis, diphtheroids, and Escherichia coli. Risk factors are excessive cleaning, swimming, and devices that occlude the ear canal. Symptoms of otitis externa may vary depending on the stage and extent of the disease. The clinical diagnosis is suggested by the presence of otalgia, otorrhea, oral fullness, pruritus, tenderness to palpation, and varying degrees of occlusion of the external auditory canal. The patient may also present with hearing loss, which results from occlusion of the external auditory canal by edema and debris. Signs of otitis externa include pain on the distraction of the pinna, external auditory canal erythema, edema, otorrhea, crusting, and, in more advanced disease, lymphadenopathy of the periauricular and anterior cervical lymph nodes. Skin changes of cellulitis may be present as well. In the chronic stage, the skin of the external auditory canal may be thickened. A culture may be helpful for infections that are refractory to treatment. Microbiology. Pseudomonas aeruginosa and Staphylococcus aureus are the most commonly isolated organisms. Less commonly isolated organisms include Proteus species, Staphylococcus epidermidis, and diphtheroids. Staging: mild, minor discomfort and pruritus, minimal canal edema. Moderate, intermediate degree of pain and pruritus, canal partially occluded. Advanced, intense pain, complete canal occlusion, plus auricular erythema. Severe, severe pain and fever, canal completely occluded, auricular and periauricular erythema. Treatment. Treatment for otitis externa involves meticulous atraumatic debridement of the external auditory canal with the help of a microscope. Thoroughly clean ear canal. Treat inflammation and infection. Control pain. And avoid promoting factors. Topical agents. Acidifying solution. Acetic acid, HCl, salicylic acid, boric acid. Topical corticosteroids. Topical antibiotics. Polymyxin, neosporin, gentamicin, tebramycin, ciprofloxacin, anafloxacin. Acute otitis media. Most commonly diagnosed illness in children. Peak age 6 to 24 months. By age 1 year 75% of children have had one episode. Pathogenesis of acute otitis media. Viral upper respiratory tract infection. Eustachian tube dysfunction. Impaired efficacy of the mucociliary system. And alteration of bacterial colonization. Routes of infection. Eustachian tube. Perforated tympanic membrane. And hematogenous metastasis. If the history or physical examination suggests evidence of prior or existing otitis media, or if there is a history of prior otologic surgery, an otogenic etiology should be suspected. Concomitant symptoms of hearing loss, otorrhea, and vestibular symptoms are highly suggestive of an otogenic etiology. Facial palsy due to acute suppurative otitis media is typically seen in children who appear toxic and manifest otoscopic findings of middle ear empyema. The palsy is often progressive over a 2 to 3 day interval. In such cases, there is often a history of recent episodes of otitis media that have been partially treated. In cases of prolonged palsy, radiographic evaluation of the temporal bone may rarely disclose coalescence of infection in the mastoid. Facial palsy associated with acute suppurative otitis media is generally the result of toxic neuritis and can be adequately treated with wide myringotomy and systemic antibiotics. Treatment of acute otitis media. First-line treatment. Amoxicillin, standard dose 40 mg per kilograms per day, high dose 80 to 90 mg per kilograms per day. If treatment failure, we give amoxicillin clavulanate. Cefuroxime ceftriaxone, IM. Thanks for watching guys, I hope you guys liked the video, and if you found this video helpful, consider subscribing to the channel.